morning, everyone. It's great to see you. I'm Gregg. I'm going to be representing a dream team here. This is actually a network of Northwest London, Imperial College, where I'm from, and Leicester, around a network of studies assessing the effectiveness of NHS-based multi-tiered lifestyle interventions across diabetes, type 2 prevention, and glycemic risk tiers. In brief, So the rationale for this, the premise is that there's strong evidence that lifestyle interventions, structured lifestyle interventions, are effective across multiple stages of glycemic risk, from pre-diabetes to diabetes. And they're being implemented. The questions that are important right now, though, for key importance are, do they work in the real world as they're implemented? And when they are, do they have the same effectiveness according to risk groups? And to what degree do we see actually inequalities in that delivery and in that effectiveness? So we're going to share for you basically an update on two particular projects, studies underway. The first is Rewind, which is a community-based weight loss program in Northwest London aimed at diabetes remission using total dietary replacement or low carbohydrate diet. And then the second that you'll hear from our Leicester team, thank you there, is Baby Steps, which is a digital application for gestational diabetes, also aimed at lifestyle intervention, but in this case for women with a history of gestational diabetes. In brief, I'll give you the overview of Rewind. This is conducted in 8 diverse boroughs of London, some of the most diverse areas of England, of course. People are referred, patients with diabetes, diagnosed diabetes, are referred from general practice into a 12-week de-prescribing protocol. Excuse the misspelling here. 2 dietary interventions are offered: total dietary replacement, akin to the original direct clinical trial of remission, and then a low carbohydrate intervention, and then a virtual lifestyle intervention is carried out through 10 group sessions, phone calls, online support, and then health checks as well. We're going to share for you very briefly some preliminary quantitative findings and then some qualitative findings. This is on the left side, the actual scale up of the program starting in December 2019. There's actually, there was a pilot done right before COVID, and then you see it plateaued a bit. But then once the program got its feet under itself, actually during the COVID pandemic, you can see there's actually been quite a rapid scale up, such that there's been about 5,000 plus participants at this point, distributed roughly evenly, a bit more in total dietary replacement, which is this that arrow? There we go. This is right here compared to low carbohydrate. Now the next slide on the right shows what happens after they get referred. And basically you see of that 5,000 that are referred, about 56%, well, a little bit less than half actually, show up at all, okay? And then among them, actually a good percent start, about 80% start. And then this is a subset for whom we have data on, or that we'll present to you, that had the opportunity to finish. In other words, they've been in the program for a full 12 months and we have data for them. And then there's basically another drop-off, though, that among those with about half complete, 60% complete among those who started. So I'll share you very briefly one of our key findings so far. This is actually just from the intervention condition. There's no control group in this yet. So this is a control group, intervention only, but this is change in hemoglobin A1C over the course of a year. And what you see happens here in low carbohydrate and total dietary replacement, there is a reduction at 3 months, quite large with total dietary replacement. That's a large drop, 9 millimoles in 3 months, but you can see what happens here. By the 12-month period, that has essentially disappeared overall. Now these are all people who are referred, regardless of participation level. If you go to those who had the opportunity to finish and completed, defined as attending at least 60%, you see that again, it's a large reduction in A1C that does have a regression, and it's sort of either modest or non-existent change at 12 months. This is technically, well, quite borderline statistically significant here for the low carbohydrate. But the point is that there is a drop-off, in terms of this effectiveness that our next analyses are really trying to understand. At this point, I'm going to hand this to my colleague Salma Mehar, she was instrumental really in developing this program to start with, and she's overseeing the patient, provider, and qualitative aspect of this work.
Thank you, Ed. So I'm just going to talk you through a little bit about the qualitative analysis that we're conducting at the moment for the Rewind program. So if we have a look at the Rewind program, there are 4 main key stages that we wanted to understand the patient user experience. And these 4 reflected on when they were initially referred into the program and the process of being referred in terms of equality of the 2 different programs that were offered. Then we went on to look at whether the patients were actually starting the program and the reasons to drop out of the program. And that's really important to us, trying to understand what is the reasons to why people are dropping, as we saw the 40% uptake on referral. Then we went on to look at how the program was designed and developed and whether people are actually wanting to stay on the program and then completed. So just to add, when we designed this program, it was actually started prior to COVID, and because of COVID, we were not able to offer this program as a face-to-face program. It went on to a virtual set program, which had its own challenges as well for both us as healthcare professionals and also for people wanting to start the program. We've also wanted to understand healthcare professional experience, because as this is a new area of work, because remission is a very new interest, and wanted to understand the challenges that primary care would be facing both on referral as well as the monitoring that is attached when allowing somebody on a remission program. And then lastly, the provider service. So what are the challenges and the barriers for providers when offering a new program like a remission program? Oops, what have I done here? Have I just switched it off? Beg your pardon. Oops, IT? I just pressed the middle button, it's just switched off. Sorry, we will be right back with you. Technology. We're back. And I think I'll just, which one is it? Downwards, okay. So part of our analysis involves participants who have been involved in the various stages of the program, healthcare professionals and commercial providers. And we've sort of subgrouped the feedback that we've been getting from participants, and the common themes that we're getting from a program like the remission program when we're wanting to start is the challenges between participants, primary care and providers. And this can be very frustrating for individuals wanting to go into the program and not knowing exactly what is going to be offered. The second most difficulty participants have fed back is the learning online and the use of applications. As we know with COVID, some of us have been very savvy, but we need to recognise that not all participants are familiar with online usage of education as well as apps. And then moving on to healthcare professionals, again, we've heard some of the challenges with primary care involved with the monitoring and communication with private providers as well. And with the providers, one of the biggest challenges in North West London is that we have over 150 languages spoken in North West London, and this can be a barrier for people wanting to start a program or even wanting to know more about a new program. I would like to mention that the Rewind program has heavily involved the community and co-design process from day one. We are very, very privileged to be working very closely with our communities and in the heart of communities, which will involve people from voluntary organisations, community sectors, and from the local health authority. We've translated materials into different languages. We've involved social media, Facebook pages, where we really want to be promoting and uptaking people onto this program. Here are some of the recommendations, but I'm going to hand you over to my colleague who's going to talk about the next stage of the program. Thank you.
Hi, so I'm here representing the Leicester part of the project, which is baby steps implementation. So we have a program which is an app-based program for people who've previously had gestational diabetes to reduce their risk of going on to have type 2 diabetes. We implemented it from scratch, which may be different to a lot of projects that are being presented today. As you can see there, we've had 9 months of recruitment. You can see the age group there. We've had around a quarter of the population who are from a South Asian community. As I'm sure people are aware, in Leicester, we have a fantastically diverse community in Leicester. Lots of the strategies we've used have involved community settings, but actually the two strategies that have worked the most, one of which is slightly controversial compared to Paul's comment earlier, is text messaging, which we found very useful in this particular population. So our next steps, having implemented it, are to continue to project to the end of next year. We're going to use nudge reminders, as we found text messaging worked very well. The evaluation process, we're looking at the demographics of the cohort. We're going to be looking at wellbeing questionnaire, finding out what people have got out of the programme, and there's a discrete piece of qualitative work looking at the use of the app. We're disseminating it through publication, and most importantly, our outcome of the implementation project will be a toolkit to inform other people who may want to present this and use this elsewhere. We've already scaled up in terms of implementation, and Baby Steps is now available in other areas outside of England already. In terms of the findings elsewhere and the next steps, so Rewind will go on in an app-based form. They're looking at the achievement of HbA1c changes, the greater outreach on awareness with cultural and language-specific tailoring, and how that has improved the cascade of referral into onboarding. The next stages for them are more stakeholder engagement, which will modify Rewind, and, as I say, the continued scale-up of Baby Steps, both nationally and internationally. Thank you very much.